So it's a great pleasure to introduce Katt, and I was at a national opioid conference in November in Ottawa, at which May spoke very, very eloquently and very passionately about her work, and it was the first I had heard about her work, and so I managed to kind of wrangle her at a break. And meet her and talk a little bit about Yukon, and following that was we were able to connect. So I feel very lucky that that we have Katt with us for today. May's a primary healthcare nurse practitioner. She holds a degree in nursing and a master's in education. And she has a diverse nursing career spanning primary healthcare, mental health and addictions, adolescent health, maternal and child health, and community health. And she's worked as a senior administrator responsible for First Nations health programs, both as a regional director for Health Canada's First Nations and Inuit Health, and as a health director at the Nishnawbe-Aski Nation, which represents 49 First Nations, a total population of 50,000 Ojibwe and Cree living in rural and remote north. May's a member herself of the Temagami First Nation, and she coordinates a mobile treatment team that provides opiate agonist treatment with Suboxone in remote and rural First Nation communities. Her on-site Suboxone program at a First Nations high school, and you'll hear more about that story. It's an amazing story, but it's been successful in dramatically reducing opioid use and addictions in that special population. So I'm going to let May carry on with her first talk on community wellness and treatment.
Thank you. I'm really pleased to be on the traditional territory of the Kwanlundun First Nation and the community who they share this territory with. And it's amazing to be here with the sacred fire. It's not every day you get that, so thank you. I'm gonna do a couple of things with you today. I can answer any kind of question. My hopes is that I bring hope to you and the work that you do. I've been a nurse practitioner for many years, a nurse for more than that. I'm going into my 4th decade. I know I look very young, but I have lots of miles on this body. But you don't become a nurse, I think, just out of the blue. Those of you who are service providers, there's somebody behind your story. And my story starts with my grandmother, who was a traditional midwife, and my mother, who was a caregiver, who we call a natural caregiver. So although I identified to Santa Claus at 8 years old that I wanted to be a nurse, it's been a lifelong, I think, seed that's been planted by my family. And one of the things that my family did was they raised me on the land. I was very fortunate that I grew up in a very traditional environment, that the land, the animals, the plants were a big part of, and the water was a big part of who I was and what I became. So when I talk community, I can't really see my presentation, so sometimes you're going to read what's on there and it's not even going to be what I'm talking about. So, here's the clicker. I know everybody has struggles with this morning. I'm going to see if I can do it. Oh my God. Okay. So here's where we work. We work in northwestern Ontario. All those little dots that you see are really what we call First Nations. I work in a territory that has 50 First Nations, 49 First Nations, 50,000 Ojibwe and Cree. I was their health director for many, many years, which means I have a very strong policy background, but it's a very land, people-based policy background. I also worked for the federal government, which means I also can do that kind of policy. It's not as successful, let me tell you. So our communities are anywhere from 200 to 3,000 population. very distinct, very culturally intact from a language base. But over the years, we've seen some impacts of colonization, of a very unkind history in this country in relation to our indigenous people across the land. So I'm going to talk to you about our community wellness programs. We've been doing Suboxone treatment for over 5 years, and we've been documenting, the lady this morning said evidence-based, so what we've produced is a set of about 6 literature articles. We call it practice-based evidence. So we had to show the broader scientific community that whatever you do in a community can be documented, and it can give you good results as long as you listen to the people. We call them community wellness indicators. I'm going to end this talk about First Nations mental health continuum framework, which is our view of health. We haven't lost that view despite centuries of colonization in this country. So our community-based Suboxone programs, we started rolling out our programs in 2011, but years before that, we were starting to see things that were very disturbing to people who lived in our community, the young people, the older people, our leadership. The drug Oxycontin, you all remember that drug and the destruction it has caused across this land, not just here, but in other parts of the U.S. It was one of these drugs that was highly marketed and taken up quite quickly in our community. Our community is all remote. You have to fly there. There's a few that you can drive to. So we were taken quite highly by this drug. People took it up in great amounts, many people. I do Suboxone treatment. My youngest patient was 15, my oldest is 66. There's no age group that has escaped addiction in our communities. We don't talk purely opiate addiction. We talk a lot about other substances, and I'll show you some of those substances when I do the adolescent presentation. And it all started with the alcohol after, I think, I noticed it when I first was a nurse and sitting in Sulaka, my first job, right? I mean, all of a sudden you have this sudden affluence. What are you going to do with this paycheck? I worked in a federal hospital. What I noticed there was a lot of homeless people, and they were all Aboriginal. And I asked somebody, I said, how come they don't go home? And the response I had is they don't have a home. They don't know their home. They've been in school since they were little children, and they've been disconnected, which was really sad, And I think in some ways it kind of steered me into the area of mental health. And I've been doing mental health almost exclusively throughout my career. So what we did with the opiate addiction is our leadership asked for some support. They asked the health professionals who work for them, and that's exactly who you are today. How can you help your community? And there's many ways that you can help. I think you all have a job description, and I'm sure many of you don't follow it. You do other things. I love the North because I think the North is one of the places where you can be very creative in how you deliver services to the people that need them. So what we've had to do with our opioid addiction in Northwestern Ontario is we were seeing communities, 50 to 80% of an adult population addicted to Oxycontin. I went to work in one community in September of 2011. They did a community wellness assessment. They counted everybody in that community to see who had an addiction to an opiate drug. From the ages of 16 to 65, which is your workforce, only 8 people did not have an opiate addiction. They identified 63 people required treatment. I've been in that community now 5 years, and we've treated exactly 63 people. And we have treated successfully some people who are no longer on Suboxone. And with our 22 programs across the north, we've been able to deliver a Suboxone program. I call it Suboxone only because that's what was on the market. In 2011, when we rolled out our treatment programs, you didn't have generic buprenorphine naloxone. So that's what our patients were started on, and that's what we've continued them on. In 2012, we produced some literature. Again, these practice-based evidence, the first article we did, I was the first author on it, was based on this small community. But we actually showed that it was feasible to do short-term, low-dose treatment. One of the things that our chiefs told us is that we do not want people on methadone for life. We don't want people having to be confined to a city and not be able to go home. So we had to, again, as clinical professionals, listen to our leadership. And so we rolled out a program which is mostly low-dose, short-term treatment. The band councils own our programs. They're the ones who make the decisions. Where I work, they have signed band council resolutions, or they've signed letters saying, we want to do this in our community. One of the things that we do well, and we're forced to do, is grief counseling. I do a grief model, traditional grief model. You know, it was taught to me a long time ago. When I say a long time ago now, I think the 90s. It was by a psychologist and a pipe carrier. His name was Dr. Ed Connors. And so I've been using this grief model in all the work that I do for the last 25 years. And I ran into Ed a couple of weeks ago, and I said to him, you know, I talk about this traditional grief model, and I always attribute it to you. I said, is that true? And he said, yes. So it's a 4-step, very easy model. You know, you talk about denial. Here I'm off script now, can you tell? You know, you talk about denial, you know, deny that there's really a problem. And then you get into this phase of anger. Now, in the anger phase, there's a little sub-step, and it's called forgiveness. And it's where you forgive yourself that you didn't cause what's happening to you. And then you can go on to acceptance. And then the final step is what they call reconciliation. And after reconciliation, there can be a broader forgiveness where we don't force people to forgive perpetrators, but if it happens, we say it's a result of healing. So that's the grief counseling that we do. A big part of our program is not just putting a pill under somebody's tongue and waiting the 3 to 7 minutes while it dissolves. Our program is about being supportive, doing the grief counseling, helping rebuild families again, and employment, education, land activity, get people back out onto the land. We find that, you know, if you look historically at who we were, our land was so protective. Our land taught us things about our heritage. It taught us things about who we were in this bigger world. I work with adolescents, and that's one of their questions is, who am I? And without that link to their heritage, their aunties, their uncles, their parents, they don't, you know, they still do. I think what happens is they don't feel that strong foundation. They know who their relatives are, but they don't have the experiences of, I was out cutting wood, I was out catching fish, you know, I fell out of the canoe when that person tipped me over. So those are the kinds of land experiences that help people get better. What's on the bottom of that? Our language, again, is so important. You know, we have people who in our communities that teach our little people the language. I heard a couple of young people talking about fighting over if they were going to have potatoes, and they were doing it in their own language. I thought it was actually kind of cute. You know, strength-based approach, if you all think about your own families, regardless of which culture you're from, and, you know, even if there were, you know, not everybody had a great upbringing, you know, you don't have to be Indigenous to have had some things happen to you in your family. But I think if you look at the strength of your family and what it brought you, I love the story about, you know, learning how to adore someone. You don't see that very often, but when you do, it's just so heart-lifting. So the strength-based approach is, let's look at what's good in what we have. And you were doing a discussion this morning, and that was there when you're talking about how can we do this. Yeah, it seems like an insurmountable problem. When we had so many communities with an addiction, we counted 9,000 people had to have treatment. Now 9,000 of 30,000 is a lot of people. We've only been able to do about 2,000 people with Suboxone. Let's see what else is on this slide. Did it change? No. I'm getting a full color here. There we go. So the community, I'm going to stand over here, okay, because I have some numbers to read here. Can I do this? Is that okay? So our community wellness programs is we ended up doing a research project in one of our communities where we had a Suboxone treatment program. So we've had 186 people in this community of 800 on Suboxone. Can you imagine that every day going to give 186 people medication? That's what they do. And so from this community, they've also set up an aftercare program where counselors will do the counseling, other people will do other activities for them. So the clients go every morning to this little house where they actually get their Suboxone. And they can go at lunchtime depending on whatever hours that this facility is open. So when we were looking at our communities, we had the murders, the arson, the drug-related violence. So when we put in treatment, the drug-related medical evacuations like assaults, suicide attempts, overdoses, and sexual assaults, those all went down by 30%. Our needle exchange dispensing, I know somebody was talking about harm reduction. Harm reduction isn't greatly embraced, but again, if the health providers are saying, yes, you need to do a needle exchange, it hasn't been outrightly resisted by our communities. But we saw that dispensing decreased by more than 50%. The children and the elderly patients were being taken in earlier for medical care. So if they were taken in earlier in illness, that meant that they didn't have to get medevaced. Again, remember, we fly people out to our health services, our hospitals about 300 kilometers away. Our nursing station, you have nursing stations up here? Okay, so what our nursing stations were doing, they were doing all it was becoming a trauma center. So once we put in treatment, then it became more of a primary health care center. People were, coming in for their well women, well men. Children were coming in for their immunizations and their growth and development assessments. Our seasonal immunization rose dramatically, 350%. Can you imagine people working in public health saying, wow, this is great. That was flu shots. School attendance increased by 33%. I worked in one community where I ran into the principal on the way to the store, and she says, I bet you I can tell you who's in your program. And I said, well, I can't confirm that. And she said, I'm going to give you 5 names. So she gave me 5 names, and I kind of nodded, and I said, how did you know? She said, the kids are coming to school, they have clean clothes, and they're not hungry. And I thought, wow, so it's your first sign of what can you see in a community if you provide treatment. If you can take the drugs away, there's so much that you can do. You have something to work with then. We were very sad in the beginning of our opiate crisis, that lots of our kids were leaving the community. They were being apprehended by our child welfare organization. It's an Aboriginal child welfare agency, but they were taking our kids. They didn't have homes in our community to place these children in foster care, so they had to leave the community. I worked in one community where I started working in a second community, and all their children were in that one community. So they got taken out of their home into another community. I was there when these kids came back, when they got repatriated back to their families. And you know what? These kids came back angry. They were angry because they had to leave because their parents did drugs. So people working in child welfare, it's real. It's real what's happening with the behavior of these young people. And so we don't have child psychiatrists. I don't think we need them. We have some really good people in our community who can create different memories for these kids. So what we said to the parents is, make a fire in your backyard. Campfire, not make a fire. Buy some wieners. These kids remember bad things, so make new memories for them. That's how you bring your kids back to you. And that's what they did. So our child welfare cases fell by almost 60%. So we don't have masses of children being traumatized by having to leave their home community. When you look at the attendance in the community events, our summer carnivals, our gatherings, our feasts, our Christmas dinners, there's just so much activity happening in our community. Our local store, we had a store, the Northern Store. You guys have Northern Store? Okay, so what was happening in a Northern Store, they brought in an ATM machine. So what was going on was the drug dealers were just going to deposit all the money from the paychecks or the child tax benefits into the money machine, and it was leaving the community. When you went into the store, there was nothing, the groceries weren't being sold. There were no toys in there was no fishing equipment, anything in the store. And I'd been up there 20 years before that, and I thought, wow, things have really, really changed. So now people were buying food. The police were really happy. Suddenly there were criminal charges decreased by 61%. A lot of my clients were charged. They were charged with trafficking. And I had to write a lot of letters to probation officers saying this person's in treatment, community-based treatment, and this is how long and this is how well they're doing. And it kept people out of jail. And people were rebuilding their lives, so the justice system was very supportive of that. They encouraged people, where I come from, child welfare says to a mom who's lost their child, you have to go for treatment. And what they mean is you have to leave your home, find a babysitter, and go away for 30 days, and you're going to come back and you're treated. That doesn't happen. People relapse when they come back. So what we were doing was we were giving Suboxone treatment. We were doing community-based treatment, and people were progressing, and they weren't relapsing. The programs where I work, I'm in 6 communities right now. Our retention rate's over 90%. And you say, why? I couldn't tell you. I can give you some ideas. But one of the reasons is you're not sending them anywhere. They're not leaving home. They're in the community, they're working in the band office, they're working in child welfare, they're working in the schools. They have employment, and they're doing things that they want to do. They're meeting their goals. So we did some articles. Again, there's 6 articles. I will send it to the conference organizers. When you talk about evidence-based, We looked at retention, and we had this discussion this morning on urinary drug screens, and we do them. The program I work in, I'm in a mobile treatment. There's a doctor, a nurse practitioner, an addiction counselor, and a case manager. I travel into these communities. I get on the plane regularly. And what we do is our urine drug screen protocol is day 1, day 30, day 90. I couldn't even tell you when day 90 is. Is it day 90 days after day 1 or 90 days after day 30? It doesn't matter. If people say they relapse, I don't test their pee. If people say I'm doing really well and they look good, I accept that. If I see them doing things in their community, they're not relapsed. When you see somebody who has relapsed, you can tell. You don't, and they're not very proud of that. So you just deal with the remorse, right? And you tell them to go back into the treatment. So we did the urine drug screens, but what we found there was at 6, 12, and 18 months, we still had a high retention. At 6 months, 84%, 78% at 1 year. And I think if we would have kept tracking this, we would have still seen over 70% retention. I come from an area where we've had over 500 suicides. That's a lot of young people in 25 years committing suicide. You look at, and we haven't been able to answer those questions of why. Our young people, suicides are getting younger, 10 years old, 12 years old. We can track a sexual predator in our area who was there, who had over 500 victims. That was some of our earliest suicides. Now we're not sure what's going on with our young girls. We think some of it is bullying. The source of hopelessness goes many generations. The lady who talked about intergenerational trauma, these communities were all traumatized by history, by things that you had no part in, I had no part in. But they traumatized every generation in our communities right across the land. I haven't been to one Aboriginal community yet where you could not put your finger on some historical event that changed that community. So we have 2 studies also looking at Suboxone in pregnancy. We don't put women on methadone even though they say that's the gold standard. We put them on Suboxone. We apply for Subutex. Subutex is the buprenorphine only that's free from from the drug company. If Health Canada says yes, you can go on to Subutex. So we've been doing that. With Suboxone, we're not finding any neonatal abstinence syndrome. We see a little bit mild, so mild is Finnegan's score under 8, I think. So when I see babies, you might see a little bit of nasal discharge. They're sneezing. They might be a little jittery. They're having baby poop, but that's baby poop, right? It could be diarrhea, who knows? But anyways, that's what we see. So if you're under 8 or 6 milligrams of Suboxone, these kids do not need 2 weeks of morphine for withdrawal. So we talk about culture and land-based activity, healthy living for our children and youth, positive parenting again. We see a lot of things happening in our communities, but that's really essential to healing in all our programs. That's going to be essential for what you're talking about here today and tomorrow. We see lots of PTSD. Somebody talked about anxiety. We see lots of anxiety. As soon as we start providing treatment, people will say, I can feel my feelings now because I don't have the drugs and I don't have the alcohol. And so you have to deal with that. And if you listen, if you support, if you can talk about grief, you can help your client. We look at, for First Nations, we talk about hope, meaning, belonging, and purpose. This is a First Nations mental wellness continuum framework. It looks really busy, but really it's talking about culture as being the circle that we have. You can actually look at this under Thunderbird Partnerships website, Thunderbird Partnerships Foundation website. And so the center of that is hope, meaning, belonging, and purpose. If you can provide that to your client is going to get better. And if you include the outer circle of their family, their community, anybody else who they have to connect with, then you'll actually see some really good results. This is what we're all about, the little people. I think every one of you in here know that if you're a mother, father, an auntie, a grandparent, it's all about the little people. You know, the things that we do make the world safe. We talk about cultural competence, cultural safety, and we can do that. We can do that with the conditions we have today. We can create that world for them. That's it.
Thanks, May. I'll stand back over here. We're going to have time for a few questions on this presentation before we move into part 2 of May's. So I wanted to just start off with a couple of questions. And one of the questions we had as a committee was looking at, well, what systems did this take? Like, how did you get this set up? And I'm hearing some of the answers, about creating a system that enabled this. And it sounds to me like part of the system is having not, as you said, not just a pill, but this is that the pill is part of a program of community support, of connection, reconnecting with the land, reconnecting with language and culture, and also you had permission and cooperation with the chief and the community, and even perhaps some conditions from the community. We don't want to see. We want to see low doses possible. We want to see shorter duration. Or it sounds like there was a kind of a contract almost. And are there other kind of system elements, if we were contemplating this, something like that here, that you would suggest? And then the second question would be, what barriers did you encounter, and how did you overcome any barriers towards instituting this?
Okay, so our biggest, there's naysayers, right? Wherever you are, wherever you go, whatever part of the world you're going to be in. So we had lots of naysayers. We had people tell us, this is not going to work. You can't do that. Man, you tell an Aboriginal person they can't do anything. They're going to show you that you can. Now, partnerships is important because what we did is we established a partnership with the Center for Addiction and Mental Health. We knew when we were doing the high school program that we were going to have lots of scrutiny, professionals, parents, leadership. So we had to provide a really tight program. So we had to follow clinical guidelines. There were none in Canada at the time. This is February of 2011. So we used the US guidelines. It said first line treatment in adolescent is Suboxone, so we used it. We set up a wraparound program, so that was the naysayers say this is not going to work, right? So in some ways, when you talk about proof of concept, practice-based evidence, you need to be able to document. The other challenge was to get the government to fund us. They would, under a pilot program, I liked Sharon's comment about her pilot program this morning. It turned into a full-time program, but we piloted the adolescent program. Government agreed to fund the Suboxone for us, and they agreed to partner with us for our first 50 patients, and then they pulled out. The province agreed to stay with us, so. In some ways, the barriers you can overcome if you're showing that you're conscientious professionally, but you're also providing a program that they recognize as primary, secondary, tertiary prevention. So if you combine traditional Aboriginal with scientific, professional approach, what are they going to say? They didn't say no. So.
That's great because you answered really both questions at once. The systems that you set up, including that cooperation, finding those partners, especially funding partners. And we had a similar lesson. Really, the take-home naloxone program here started as a pilot that we hoped would show success enough to expand into government adopting it as a long-term approach. So lessons learned. If there are other questions for Kay, Patricia. For May, sorry.
Hi. Thank you for your presentation.
Yeah.
Okay. Oh, there we go. Okay. Hi, thanks for your presentation. I'm wondering if you could speak a little bit more in detail about how you achieved buy-in from leadership in the Indigenous communities that you were working in, and how you were able to deal with the messaging that sometimes that we see at leadership level often is around an abstinence-based argument, like what we really need is more treatment, we need people to get clean and sober, that kind of stuff. And what you really brought in was a harm reduction program, and I think harm reduction is met with resistance a lot. And at the leadership level, I'm wondering, how did that get championed? How did you get that piece in? Because it's so essential, I would imagine, to the success of your program, and how you managed to achieve that buy-in and what that message was, or who the champions were on that. Could you speak to that a bit more?
Yeah, there was really two key things. One is people have to trust you. I was a known face to the chiefs. We have 49 chiefs. I was their health director. I work at their high school. I've been there for 14 years. So when we went to them to say, we want to treat your young people with this medication, and here's what the benefits, here's what they're doing, here's what's destroying their lives. So trust is something. So if you have somebody in the room that's trustworthy, you use that person. The other thing was we had some chiefs who, again, didn't like the social problems in their community. They saw the grandmothers raising the children. They saw the people who were, homes were getting broken into. They saw all the social things. So they became the spokespeople. And if you talk about peer pressure, it happens the same way with our leadership. They were able to convince the other chiefs that let's try this, let's do this, what are our options? So it's when you can present something from someone else, I think they were able to listen a little more openly. Our biggest criticism was you're going to just replace a drug with a drug. And so we've been able to convince people that that's true. It's substitution treatment, but we're going to follow what you want, and we're going to work with your clients, and we're going to do short-term, if we can, short-term, however long, depending on the patient, and low dose. So that was the kind of we don't go beyond 16 in the program I do. The physician-led programs, again, we have the two models, treatment team and then physician-led. Some of those doses are a little bit higher, but they eventually come down, and then people are tapered off Suboxone. Okay.
Other questions for me?
I wanted to, there was the question before, which was what were the barriers? We were told by Health Canada, who work in our nursing stations, that they could not work with Suboxone. And so that kind of thought, okay, now what do we do? So in Ontario, we have a practice guideline for nurses, and it's called Working with Unregulated Care Providers. It used to be on the back of our medication standards of practice, but what it says is you can give a layperson the responsibility to administer a medication. They're not responsible for monitoring the patient, they're not responsible for changing the treatment plan. So we use that unregulated care provider practice standard to train our community-based workers on how to administer Suboxone 7 days a week.